As people involved in drug development, it's probably happening at all our centers, but I didn't check. I mean, how much profiling are we doing when a doc says, okay, I've given my third-line therapy in colon cancer, and they come and see us in our phase 1 units? Are we still sort of throwing the dart, or is there more profiling going on in treatment assignment? What's going on in San Francisco?
That's a great question. In San Francisco, it of course depends on the referring physician, on the patient, how much time they've spent on the internet, their means. We see many patients who have had their tumors profiled, usually by a commercial outfit. We profile all of our patients. I think.
What do you mean by that? So what technically, well, to set expectations, they send a patient to you to be seen, is it a fresh biopsy? Are you taking weeks to get analysis?
These are the moving parts, and this is the challenge. So we have many of our patients come with a commercial assay in hand with a printout of the, quote, actionable mutations, most of which are not actionable but are called the theoretically actionable mutations. We certainly ask for a BRAF and a KRAS analysis right up front. We do that on all of our patients immediately. We believe BRAF patients with BRAF mutant patients are different, and we look, in fact, nationally, there's a study that will look to treat them differently right out of the gate. We will often have, let's say, a Foundation 1 assay, which may give us some insight or not. The dilemma with BRAF mutant patients, for example, is that they do poorly to the point that you may not have a lot of time to characterize their tumors once they fail first line. So we push early on. The right workup, the right evaluation, I don't know. Now we'll add, we're doing expanded RAS. This is a problem. Nationally, the goal is to create a method to actually assign, and the name of the study is called the ASSIGN trial, to take patients with first-line treatment who have reached stable disease to consider introducing these agents into sort of buckets based on a mutational analysis. So our goal is to characterize these tumors thoroughly right out of the gate. Dollars matter, insurers, who covers it. Most important, how do you interpret it? And so this is a huge challenge, but one we have to face right up to because we're doing it, but what we learn, we have to be able to export to the community.
But as GI docs, we're behind, right? I mean, there's the battle study in lung, there's the I-SPY2 in breast, we're behind,
I think we're behind, and it may be that if the cancer, I'm not sure there's a crizotinib for colon cancer is the problem. And so the key question is there a pathway that's so important to a colon cancer that it will make a big difference? And I'm not sure there is.
But, we'll never know unless we get ROS and, ALK mutations on everybody that walks in the door.
You're absolutely
right. So I think it's absolutely critical that we expand our testing up front, because I think for our drug development treatment decision is absolutely critical. The question we can talk about, do we need 20 or 40 genes or 200? Right. From our center, we do extensive DNA mutation analysis covering about 20 actionable mutations. In addition to that, we look gene expression, because what we have learned is that mutation analysis may not be the answer alone, and for a lot of different reasons. The functionality about and the impact on signaling pathway, we don't understand. So you need to have also feeling what pathways are activated in concert with your DNA mutation analysis. But I think we need to move forward. The reason colon cancer is not as easy, the subgroup with lung, because we don't have driving mutations. When you look at the heterogeneity of this tumor, every colon cancer has probably around 8 to 10 mutations. But these are not the same mutation from one to the other. So the multiplex complexity and combination is a huge number. And then we think when we know 2 mutations, we can just be successful. When you look at all the development, BRAF inhibitors didn't work. We need combination. MEK obviously took some. EGF receptor inhibitors. These data are promising. We need to hit really understanding what makes this tumor grow, and it's usually not one mutation.
So the best assays you've got today, and I don't care which one you pick, and you get an answer back, okay? How sure are you that that's actually reflective of the tumor? Just, 0 to 10, 10 being very sure. So you get this report back that this is really the tumor I'm treating. Where would you put that number?
I probably put it probably in the middle, in the higher range, because
5,
I think
6, 7?
I think it's better to
7?
know than just to do blindly.
But
so
no,
I
I'm
don't-
not, that it's an adequate photo, that you've taken a picture.
I'm
Where
not
are
really
you?
Sure. I'm actually
Give me a
closer
number.
to 2 at this point.
2.
No,
Two.
I'm higher.
Well,
I'm
I
higher.
mean, wait a minute. I mean, even when you look at some of the drivers, I mean, you look at some publications looking at PI3 pathway, and when you select out and you put them on phase 1 clinical trials, zip,
But
nothing.
it's
So- so
you know,
I
at
think-
last year's ASCO, was
So-
Rachel Kurzrock showed very clearly. It was rough. The patient's profile and assigned to phase 1s versus the ones not knowing.
Yeah.
There is a survival benefit. So
But
I
2/3
think
of
that-
those patients went on a thyroid study, you know? So
Right.
that's
No,
not
you
really
have to look
fair.
at colon.
And I
You
think
have to look at
the other
colon.
burning issue I think that we really need to grapple with is we for the most part these decisions are being made on primary tissue, and of course patients die of metastatic disease. The dilemma in what I think is one of the best papers I've ever read in medicine, in cancer medicine, the Gerlinger paper in the New England Journal a couple of years ago, where they took a couple of patients with multifocal metastatic renal cell carcinoma and characterized the tumors across the metastases in the primary, and it's apples and oranges everywhere you look. Which metastasis do you biopsy? This is to remind us that what we think we know, we probably don't know. And again, this is a huge, huge problem because resistance may be that we're treating the wrong mutation. We treated X% of cells work, but it's a numbers game, and given the number of mutations, it may just be that we can't get on top
But
of
I'm
it.
sort of with Heinz about, well, we got to just start. You know, if we're going to really learn, and we've got these assays out there, we ought to at least, instead of shot in the dark, at least try and pick.
And I'm not saying
sort.
that-
But I agree with what Alan said. Highly variable. Which assay you use, we're fighting about that too. Is it protein? Is it DNA?
What's
Is it
actionable?
circulating?
What's
What's
not
actionable?
I mean, even if it's actionable, do you know the drug that's available hits the target right?
don't.
And so it's a lot. I mean, I think we don't want to give a false kind of confidence here. But it does make sense. I agree. I mean, having some data is better than not having, and collecting it and knowing. I mean, if you collect the data and you know that this marker, even though I thought it was actionable, I used these drugs and it didn't work, that's helpful information.
So if you could design this system, the network, your referral network, and so patients, colon cancer metastatic, progressed on your last line of therapy, whatever you have to offer, and still great performance status and want to refer to a center for a new study. New biopsy, molecular profile in advance of the referral. Would you like that?
No, I'd
No.
rather have the patient come to
You
our
want
center.
your own tissue.
And we'd want our own tissue.
So don't tell the gang out there, don't do it in advance, or you
I think we're heading this direction.
Yeah.
Most of these new clinical trials require fresh biopsy because we know the changes of molecular makeup of these tumors to survive. So I think it will become much more critical, and we need it to decide if our approach.
Do you want
really
to
is
do
right.
it, or do you want the community to do it, Heinz?
You know, I don't mind. I probably, for the complexity, sometimes with the fresh frozen and the preservation, probably easier in centers which are set up. But we can do many of these on paraffin-embedded tissue. So I'm not so yes or no, it's okay.
I was thinking many of our trials require a baseline biopsy as
Right.
part of the study, so they have to do it under
Right.
informed consent. In the Tennessee world, what would you like your gang to do?
We want them to send them in and let us do the
Let you
biopsy
do the
themselves.
biopsy.
And another part of it is just the operational part. When there's a biopsy at a faraway institution where a pathology department might not be used to sending it, or they might not be used to doing core biopsies, which is another big learning curve, that we need the cores and not the fine needles, need to get them into the centralized area.
Just briefly, I want to